Good evening, everyone. Welcome to tonight's webinar, How Doctors Choose Your Epilepsy Medications, brought to you by the Epilepsy Foundation, Eastern Pennsylvania, and it'sYourEpilepsy.com. Our speaker this evening is Dr. Christopher Skidmore. We will have time at the end for questions and answers. Before we get started, I wanted to introduce myself and our partners at it'sYourEpilepsy.com. My name is Rena Laughlin, and I am the Program Director for the Epilepsy Foundation, Eastern Pennsylvania. We serve 18 counties in Eastern Pennsylvania, as well as South New Jersey. Our mission is to stop seizures and SUDEP, find a cure, and overcome the challenges created by epilepsy through efforts including education, advocacy, and research to accelerate ideas into therapies. We offer many free services and programs. We lead seizure recognition and first aid trainings, monthly support groups, advocacy efforts, community and awareness events, educational conferences and webinars, information and referrals, youth, young adult and adult services, retreats, and camps. Now I'd like to introduce you to Clarissa Martinez-Rubio, Senior Director of Clinical Affairs and Education at it'sYourEpilepsy.com. Clarissa, the floor is yours.
Thank you, Rena. Hi, everybody. Good evening. It's a pleasure to be here today with you and to tell you a little bit about the up and coming website called it'sYourEpilepsy.com. Next slide, please. it'sYourEpilepsy.com is going to be a very specialized website where you're only going to find information regarding drug-resistant epilepsy, when and how to seek specialty care, and then all of the treatment options that are available other than medications, from invasive surgeries all the way to diet, mindfulness, and yoga. The role or the purpose of this website is to really support you through your journey and help you reach controlled epilepsy. And we will be offering unique information and resources written by medical doctors and verified by epilepsy specialists. And we'll be offering all of these resources for free. Next slide, please. If you would like to receive a notification when this website is available, please scan the QR code on your screen and send us your information. Thank you, and we hope you enjoyed today's webinar.
Thank you, Clarissa. This evening, Dr. Christopher Skidmore will be presenting. Dr. Christopher Skidmore is the Associate Professor of Neurology and a member of the Jefferson Comprehensive Epilepsy Center in the Department of Neurology at Thomas Jefferson University. In addition to caring for patients with epilepsy, he's also the Vice Chair for Clinical Affairs for the Department of Neurology and Associate Director of the Neurology Residency Program. He is committed to educating patients, families, students, and other doctors about epilepsy. Dr. Skidmore also serves as a member of the EFEPA Board of Directors and Chair of the EFEPA Professional Advisory Board. Welcome, Chris. Oh, sorry.
That's okay. Thank you very much for the introduction. Share my screen now. Okay, Rena, you can see my screen and hear me okay?
Yes.
Perfect. Okay. Well, thank you everyone for registering to meet with us today. And we'll spend about 45-50 minutes talking about how do doctors kind of choose the different epilepsy medications that they recommend for you. Second, there we go. Just some disclaimers. I do serve as a consultant occasionally for a company called NeuroPace and Eisai. I haven't done that for the past 2 years, but I have done it in the past. I don't think that's pertinent to today's talk. So these are the topics that we're going to cover tonight. We're going to talk about epilepsy, a little bit about the different types of epilepsy, kind of give a definition of drug-resistant epilepsy, kind of talk about the common terms that we use when we're describing seizures and the different types of seizures, and then talk about all the various different anti-seizure medications that are out there and when they're indicated for different types of epilepsy, talk about how we sometimes combine medications, then unfortunately talk about some of the drug interactions that you can sometimes get with epilepsy medications, whether it's two medications together or mixing it with a different agent. And then when medicines aren't working, talk about some surgical interventions and adjunctive therapies, and then we'll open it up for questions and answers at the end. So I hope I don't need to explain this to this audience that, the human brain is the most complicated organ in the body. You have billions of cells that are called neurons, that are basically our nerve cells that are kind of transmitting and controlling everything that you do. So all the information going to and from your body, all the thoughts that you have, the memories that you have, your hearing, your vision, your speech, everything is due to these neurons or nerve cells and how those nerve cells communicate with each other. And our brains are like supercomputers. They communicate by sending electrical signals back and forth between the different parts of the brain and different parts of the body. And so epilepsy happens and seizures happen when the normal electrical activity of the brain is altered. And so typically when there's too much electrical activity, and then that excessive electrical activity starts to disrupt the normal electrical patterns of the brain, and that's when we see symptoms of a seizure. There's a whole host of all kinds of different causes for epilepsy. So if we start at the very top here, perinatal, basically, you can have injuries that happen when a baby is developing in the womb, or also at the time of delivery or shortly after delivery. Those are called kind of right around the time of delivery, perinatal. Genetics, we now know, plays a role, and it's not simple genetics. Like if if I have blue eyes and my wife has blue eyes, then our children should have blue eyes, right? It's not simple genetics, it's complicated. But every year, as we go to every new scientific meeting, we're learning more and more about the genetics of epilepsy and how there are some genes that can be passed down in families that increase the risk of having epilepsy. You can develop trauma or have brain infections or developmental injuries as you're developing as a child. You can have brain abnormalities such as tumors or stroke, right? So you can have all these different causes. And unfortunately, in adult onset epilepsy, still, despite all the technology and everything that we can do, about half of people, we can't point to something and say, this is why you're having seizures, this is why you have epilepsy. So that's very frustrating, both for the individual that we're telling that to, but also for us, because we want to find those answers for you. But we do our best to try to figure out, can we identify why somebody's having epilepsy? Epilepsy is super common. There's 65 million people in the entire world with epilepsy. There's almost 3.5 million people in the United States. And unfortunately, 150,000 new people every year are diagnosed with epilepsy. So this is a very, very common disorder. You've probably heard the stat from the Epilepsy Foundation before, but 1 in 26 people will have epilepsy in the United States. So that's very, very common, and we need to kind of pay attention to that. And that's why it's so important to talk about it, to educate, and then to figure out how best to treat it. So when we talk about medicines to treat epilepsy and to treat seizures, there's all kinds of different types, and they're called anti-seizure medications. You may also hear them called anti-epileptic drugs because the abnormal electrical activity in the brain is called epileptic activity. So anti-epileptic drugs. There's also called anticonvulsants or anti-seizure drugs. So all of these names, these 4 names, are synonymous with basically being medication that is used to treat seizures. And when we evaluate people, the reality is that the majority of individuals with epilepsy are successfully controlled on an appropriately chosen medication for that individual. But unfortunately, not everyone is controlled with medication. And that's when we talk about other options. And we'll go over those statistics in a moment. So the goal has to be seizure control. So we always start here to the left. The goal has to be making you 100% seizure free if we can, because we know if that we control your seizures 100%, we know that we reduce the risk of sudden unexplained death in epilepsy. We reduce the risk of having injury and harm. People can go back to driving. And there's data that if we can completely control seizures, that people are more successfully able to complete schooling, whether that's primary school or secondary school, or be successful at their job. And so our goal is to always try to get people to be 100% seizure free. And we know that's when individuals will tell us that their quality of life is the highest. And so we do that by trying to pick one medicine to control. Why do we try to pick one medicine? Well, each of these medications has potential side effects, and we're trying to minimize those side effects. So we want to pick a medicine that works for most people at the lowest possible dose to avoid those side effects. If you keep having seizures despite being on that medication, then we're either going to do one of two things. We're either going to increase the dose, either to a point that it's at a maximum dose, or you're having side effects. And if we're at a maximum dose, or you're having side effects and you keep having seizures, we're going to switch you to a different medication. But again, the goal is typically to try to have you in what's called monotherapy, meaning one medication. But sometimes we might actually have to combine medications together. So how well do the medicines work? And there's been a whole host of studies that have been out there. This data here is from Drs. Kwan and Brody from over in Scotland. And because they have socialized medicine there, they could make sure that every patient with a new diagnosis of epilepsy was seen in their specialized epilepsy clinic or several others to make sure that patients were still properly started on a appropriate first-line agent. So if we appropriately choose the first anti-seizure medication, about half of people are going to be seizure-free and not having intolerable side effects, meaning that they can be on this medication, tolerate it, and live life. Well, if you weren't one of those lucky people that was in that first 50%, if we then choose a second medication, about another 13% of the total group now becomes seizure-free. And by the time you get to your third medicine, the chance of becoming seizure-free on monotherapy is only around 4%. And so the definition of drug-resistant epilepsy in the United States is anyone who has failed 2 or 3, certainly by 3, anti-seizure medications at an appropriate dose and at not failing it because of side effects. Because if you fail because of side effects, well, then we should try a different drug to find a drug that you're not having side effects on to see if it works. So we define drug-resistant epilepsy for those individuals who have failed and are continuing to have seizures despite being on 2 or 3 appropriate seizure medications. There are many different types of seizures that can be treated with seizure medication. And when we're looking at how do you pick the right med, well, we're looking at what type of seizure do you have? How often do you have your seizures? Are you having seizures once every 4 months, where I can then start a medication that's going to take 8-10 weeks to start? Or are you having seizures multiple times a day and I need to get you on a medication that's going to be effective within a few weeks? Age plays an important factor, right? Both from the very young to the very old. So there are some drugs that are, in children, dosed based on weight. Then you become like a teenager, adult. We don't worry about weight dosing so much anymore. But then you get older, our metabolism in our body changes, and we have to sometimes adjust the dosing in the very old as well. Your lifestyle. Are you extremely active? Are you home once a day? Are you home multiple times a day? Right? Because some of our medicines we can give once a day, some twice a day. There's some that are 3 times a day. So we want to try to match our dosing of the medication to match your lifestyle. And then if you're thinking about becoming pregnant or you currently are pregnant, there are medicines that are considered to be more favorable and other medicines that are less favorable for pregnancy. So if we look at the types of seizures that there are, and this is the new seizure classification that came out from the International League Against Epilepsy in 2017. You have different seizure types. So at the very top, you have focal onset seizures, generalized onset seizures, and unknown onset. So that means I have an EEG going and recording your brain waves, and I can see whether it starts in one spot or multiple spots, whether it starts all over the brain all at once, or I can't tell based on looking at the brain waves where it's coming from, and I can't tell if it's focal or generalized. This then translates into focal epilepsy, generalized epilepsy. Some people have both focal and generalized, or we can't tell. And then you have very specific epilepsy syndromes, which is now a combination of both EEG, the electrical waves, the types of seizures people have, maybe the types of other comorbidities, such as attention deficit or intellectual disability or weakness. And then you get epilepsy syndromes. So some common syndromes that people may have heard of: Lennox-Gastaut syndrome, Dravet syndrome. These are very specific disorders that have a whole constellation of physical exam findings, EEG findings, seizure findings that all kind of help the doctors understand. So if I call my colleague up and say, I'm treating somebody with Dravet syndrome, they can immediately understand the type of patient that I'm treating, so I don't have to go through all of these steps to explain the type of person that I'm treating as we're talking about a case. Comorbidities in epilepsy, though, can't be ignored, right? So 25 to 30% of individuals with epilepsy will suffer from depression, will also suffer from anxiety. A very small percentage of individuals can develop psychosis secondary to their epilepsy. But then there's other comorbidities, right? Do you have healthy bones, or your bones brittle? Do you have diabetes? Do you have high cholesterol? So we need to pay attention to comorbidities. And then we also need to understand the etiologies that we talked about, whether it's structural, genetic, infectious, and that kind of, all of this plays into getting us the complete picture of what type of epilepsy you have. And by thinking about all of this, we start to think about the medications that we can prescribe. So we talked about the three major categories: focal onset, generalized onset, and unknown onset. And they result in different types of seizures, right? So you can have focal onset seizures, that's focal aware, meaning you're aware of what's going on with your surroundings. Many of the auras that people describe would fall under focal aware. You can have focal with impaired awareness, where you lose consciousness or lose awareness of what's going on around you. This used to be called a complex partial seizure. This used to be called a simple partial seizure. Or you could have a focal to bilateral tonic-clonic seizure, the most severe seizure type. This used to be called a secondary generalized tonic-clonic seizure. Now it's called a bilateral tonic-clonic seizure. They took out the word generalized because we use the word generalized to talk about the EEG finding. If we then shift and talk about generalized onset, and this is not all the seizure types, but for both of these categories, I'm just giving you the big types that we typically see. You can have generalized tonic-clonic seizure, you can have a myoclonic seizure, or you can have an absence seizure. And so these are the different seizure types that can most often be seen in generalized epilepsy. And then sometimes some people have seizures that when I look at what somebody does during the seizure, I don't know what it looks like. I can't neatly put it into one of those categories, both from looking at what people do, but also looking at the EEG waveforms. You can then classify anti-seizure medications many different ways. You can classify it by which drugs treat which type of seizure. You could classify it by how they act in the brain. Do they increase inhibition? Do they decrease excitation? Do they act at the sodium channel, the calcium channel, the NMDA receptor, right? So all these different spots that they can act in the brain, or we can group them by chemical structure. And so there's many different ways that we can group the anti-seizure medications. And there's a lot of them. So this is the list of all the currently available FDA-approved seizure medications in the United States. Right, I think I lost count, but I think there's 23 here. So there's 9, there's 27 on this page. Right, so when I look at this whole list and I'm sitting down with you in the office, how do I decide which of these 27 is appropriate for you? And so I'll show you in the next couple of slides how we start to think about these medications, because some of them are, very unique. So for instance, stiripentol is used to treat specifically Dravet syndrome, right? So that's a specific treatment for a specific disorder. Ethosuximide is used to treat childhood absence epilepsy. Again, very specific drug for a specific condition. These are the rescue anti-seizure medications that we have. So these all fall into the category of a benzodiazepine. That's a group of drugs fall in the benzodiazepines. And we can use clonazepam, lorazepam, midazolam, Valium. All of these drugs, which is diazepam, can all be used. And there's some differences here, right? So when do we give rescue medication? In the adult world, which is where I mostly work, we would give rescue medication to individuals who have a history of having very prolonged seizures, right? So the average seizure is only about 3 minutes. So if somebody is routinely having seizures lasting 5 minutes or longer, we might give a rescue medication. Or when somebody has one seizure, if they're typically have a high likelihood of having a second seizure in that same day, what's called a seizure cluster. And sometimes it can be 2 seizures, it can be 3 seizures, it can be 10, 15 seizures, but a seizure cluster. So if you're likely to cluster, we'll give you a seizure rescue medication, not to treat the first seizure, but you'll take it after the first seizure to hopefully prevent you from having seizures number 2, 3, and 4. And some of these medications are oral, the clonazepam, lorazepam, diazepam. Some are nasal, and these just came out. The midazolam and diazepam just came out with a nasal preparation. 3 of them are IV, so we can use an emergency with paramedics or at the hospital. And then the diazepam had a rectal suppository called Diastat that we can also use as a per rectum treatment. So there's lots of different options and different reasons why we would choose these options for each individual patient. If we then try to group the seizure medications based on seizure type, well, almost all of them, with the exception of ethosuximide, work for focal epilepsy. And that's not surprising. So 2 out of 3 individuals with epilepsy have a form of focal epilepsy. 1 out of 3 people with epilepsy have a form of generalized epilepsy. So it's not surprising then that most of the companies, when they're developing a drug, they typically bring it to market in the United States first for focal epilepsy, because if you've just spent several hundred millions of dollars developing a drug, you want to find a drug typically that works for the greatest number of patients, because that's how they get money back and return on their investment, so they can then develop other drugs. So most of the drugs in the United States are first developed for the treatment of focal epilepsy. And then after they're approved for focal epilepsy, you're now starting to see that a lot of the other ones are then doing trials to get approval for the treatment of generalized epilepsy. So if I have somebody with generalized epilepsy, and these lists are not comprehensive, but this is the most common drugs we would use. If somebody has generalized epilepsy, I'm looking at these drugs as the main drugs that I'm going to contemplate using for that individual. If somebody has an epilepsy type and I'm not sure, is it focal, is it generalized? Well, I'm going to choose one of these drugs that's also works for focal epilepsy, because all of these also work for focal epilepsy. And so I'm going to use a drug that we would classify as a broad spectrum, meaning it treats both. Because if I don't know, I better choose a medicine that treats both conditions. And then from there, kind of fine tune it. Ethosuximide, again, as I mentioned, is unique because it only treats absence seizures associated with childhood absence epilepsy, typically. What about side effects? I mean, side effects are huge with seizure medications. Some side effects are negative. Some side effects could potentially be positive. And so we need to kind of pay attention to that, right? So the seizure medicines that are more likely to give you behavioral or cognitive side effects include the benzodiazepine family, levetiracetam, perampanel, phenobarbital, topiramate, zonisamide, in no particular order. But really all of them could do it, right? Because each of you is a unique individual, but these are the ones that tend to do it more often than not. Does that mean we never go to these medicines in somebody with behavioral problems? No, we do have to sometimes use these medications, but we might choose a medicine that maybe if somebody has an underlying behavioral disorder, why not maybe use a medicine that my psychiatry colleagues use to help treat behaviors such as valproate, gabapentin, carbamazepine, phenytoin, and lamotrigine, right? So you can, if somebody has an underlying mood disorder, maybe we should choose a medicine that maybe has a positive benefit on behavior. Certainly, if somebody has an underlying behavioral disorder and cognitive disorder, I need to counsel you when we're starting one of these other medications, because if that behavioral problem gets worse, it's not you, it's the medicine, and I need to kind of adjust the medicine that I'm giving you. Subdrugs cause weight gain. These are the ones that do it most commonly, but this is, again, not an exhaustive list. These are the ones that do it most commonly. Some cause weight loss. So again, if you're overweight and trying to lose weight, I probably want to avoid a drug that's going to cause more weight gain and maybe try to give you a medicine that might actually cause a little bit of weight loss. Some drugs can actually cause bone loss over time. And so this is, if the bone is starting to thin, that's called osteopenia. If it's become so thin that it's brittle at risk of fracturing, that's called osteoporosis. And we have to be very aware of that. And this happens both in men and women. And so we need to pay attention to our drugs and how do our drugs impact bone health. Some people might actually have a tremor. So there's this condition called the central tremor, which has nothing to do with epilepsy. But if you already are dealing with a tremor, probably want to avoid a drug that's going to make the tremor worse, potentially. And then lastly, we kind of mentioned pregnancy earlier. You know, there's no medicine that's 100% perfect. We know that all medicines increase the risk of having a baby with a birth defect. Now, I want to put it in context though. So in the United States, in just taking all women in the United States, the risk of having a baby with a birth defect is somewhere between 1 to 3%, depending on what study you look at, approximately. In women with epilepsy, that risk is doubled. It's 3 to 6%. But some drugs like lamotrigine, carbamazepine, oxcarbazepine, levetiracetam are in the very low end of that spectrum, between the 3 to 3.5, 4% range. Whereas other drugs like valproate have one of the highest risks, certainly above 700 milligrams a daily dose, can have a risk of highest close to 15%, right? So some drugs are safe for some drugs we need to avoid during pregnancy. As I mentioned to and alluded to earlier, the goal is monotherapy. We try to have you on one medicine at the lowest possible dose because we want to control your seizures and not have side effects. If that dose doesn't work, and by the way, there's no test that tells me, so your EEG doesn't tell me which drug to accurately pick. Blood tests don't tell me which drug to accurately pick. There's no test that accurately tells me right now which seizure medicine to pick for you. So we try to use all of those things that I just talked about and pick one that we know works for most people that have epilepsy like you have. But if it's not working, then we need to push the dose higher. And again, we push that dose to either it gets to a maximum dose or until you're having side effects you can't tolerate. And then typically we would try to switch to a different medication. Now, when we switch, typically you're starting that second medication and then you're on the first medicine still, and then eventually you come off the first medicine, because when we make that switch, there's also a risk of seizures at that point. And in a research study that was done by my colleague, Scott Mintzer, in a very controlled setting where we were switching medications, for people that were seizure-free, switching to a new medicine, there was a 1 in 4 chance of having a breakthrough seizure during that transition. So we do our best to try to avoid that by being very careful with the titration and starting the new one and coming off the old one. But if monotherapy, a single drug, doesn't work, sometimes we'll then try to use multiple drugs at once, what's called polytherapy. And we'll try to pick and choose medicines that might be complementary for each other. Maybe one drug acts at a sodium channel, maybe we'll pick a different drug that acts at a calcium channel. And we'll try to kind of balance out the drugs that we're giving you to try to gain control without having a dramatic increase in side effects. The reality is we can probably control most people's epilepsy with medication. But the problem is if you're in that category, the 1 in 3 people where the medicines aren't controlling it, if I put you on enough medicines, I can probably stop the seizures, but you're not going to have a really good quality of life because you're going to be half asleep most of the day. You're going to be walking around like a zombie, right? So again, it's trying to find that balance of seizure control, but also not so many side effects that you have no reasonable quality of life. And so we need to kind of constantly balance that out. Drug interactions. So as soon as you're starting to get to an epilepsy medicine or 2 epilepsy medicines, or your epilepsy medicines then mixing with other medicines that you maybe need to take for depression and anxiety, for your diabetes, for your hypertension, for your cholesterol, we kind of need to be aware of these potential drug-drug interactions. Sub-drug interactions we expect based on how they're metabolized in the body. I can say that these 2 drugs are going to interact with each other, right? So those are things that we are expected reactions that we can plan for and adjust for. Unfortunately, sometimes there's unexpected interactions between medications. These are called idiosyncratic, where you wouldn't expect there to be an interaction, but there is. And so we know, obviously, all the expected actions. We're pretty good at predicting most of and so the chance of developing an idiosyncratic reaction is low, but not 0. And so we just kind of need to be aware of that. Side effects really vary. They vary to the point that some people say, look, I'm on this med and I have no side effects at all. And I can have somebody of this similar age, similar sex, similar medication at a similar dose, and they say, this is the worst medication I've ever taken in my life. And so that is because each of you is a unique individual. And while I might tell you that the common side effects for X, Y, and Z medication is A, B, C, the reality is those side effects are what we see in a group of individuals, not in individuals. And so there are some people that have way more side effects at a low dose, and other individuals, I can push the dose to super high levels and they never have side effects. So even though we're going to talk about kind of population statistics and that these are the most common side effects, you're an individual. So if I start you on a medication, if your doctor starts you on a medication and you go home and 4 or 5 days later, you're noticing whatever it is, you should call your doctor and say, hey, I've noticed in this new symptom, could this be a side effect of the medication? Because again, you're a unique individual. And then again, medication side effects vary from medication to medication, and also vary how we combine them if we have to do polytherapy. So side effects can also vary for a whole host of different reasons. So we kind of talked about some of the medication side effects, but obviously it also depends on your comorbidity. So if you have underlying depression and anxiety, we need to be aware of that, for instance. It can be impacted by metabolism. So when I talk about metabolism, we have our liver and our kidneys do most of the metabolism or alteration of chemical compounds in our body. And then they're altered and eventually excreted out either in your urine or feces. So I will tell you, because I did a genetic test, one of those test kits for like health related things. So I know that I am a fast metabolizer of caffeine. And I didn't need the genetics to tell me. I've known this since college, that I could actually drink a cup of coffee and literally just go roll over and go to bed. But it turns out in my genes, in my body, I actually am a rapid metabolizer of caffeine. And so I don't get that jittery, anxious feeling that some people get when they have caffeine. So that's just an example where your genes can actually start to play a role in how these drugs are metabolized in your body. Obviously, alcohol and other recreational drugs can have a huge impact on how you experience side effects for medications, because most alcohol and recreational drugs are acting in your brain, the same place that your seizure medicines are acting. And so when you add the two together, you can have very bad side effects. How we dose it, right? So some people might have side effects if we're dosing it 3 times a day. Maybe we need to go to once a day dosing at bedtime, and then you tolerate it better, because when you would have had the side effects, you're actually asleep. And then when you get up the next morning, you feel fine. So the dose of the medication and the how we dose it can also have an impact. And then there's a lot of reasons we just don't understand why some people react differently to the medications. So what do you do if you're unfortunately one of those 3 individuals, 1 in 3 individuals who the medicines are not working? And that's when we start to think about what are the options for other treatments. And so the first thing we need to think about is, are you a candidate for surgery? And the reason that we need to think about that is, if you are found to be a good candidate for surgery, I showed you that, that third drug, only 4% of people became seizure free. Well, if you're found to be a really good candidate for surgery, your success rate of being seizure free at 1 year can be as high as 75%, depending on the specifics. And even at 10 years, if you follow everyone who's had surgery out to 10 years, 50% of the original group is still seizure free, which is still much better than 4%. So I'm not a surgeon, but I'll bring up surgery because if the medicines are failing, surgery can really be a life changer for people as far as kind of getting their seizure under control. But you need to have testing. You need to do what I call the discovery mission, where we basically need to admit you to the hospital to capture your seizures on EEG, so I can see what you do and I can see what your brain waves are doing. We'll get MRI scans to look at the structure of the brain, see if we can find something that is the aha for why you're having your seizures. We'll get neuropsychological testing to look and see how is your memory doing and how's your cognition doing, to kind of play that in. And then we'll sit down as a group and decide, are you a good candidate for surgery or not? And the goal with surgery is to remove or treat the affected region to stop the seizures. That's the number one goal. Our goal is to try to be 100% seizure free. But if we can't completely stop it, can we at least reduce the frequency of the seizures and reduce the severity of the seizures? And again, there's been ample scientific data proving that we do this. But, and this is also confused people, they say, well, I did surgery, I'm not having seizures, why aren't you stopping my medications? And the reality is, because we know even in that best group where 75% are seizure free at 1 year, and then out at 10 years, 50% of that group is now seizure free. That means between year 1 and year 10, 25% of people had a breakthrough seizure. And so it's not uncommon that for some period of time after surgery, you're going to remain on your medications, and then they will be slowly lowered and potentially stopped, usually years after surgery. And that varies a little bit from doctor to doctor. So, but certainly almost all of us, unless there's a major reason, try not to alter your medicines at all in the first year. So what kind of surgical options are there? Well, there's some stereotactic, very small, minimally invasive surgeries called stereotactic laser ablation. There's your traditional surgeries, and you might have heard of like doing what are called temporal lobectomies or partial frontal lobectomies or hemispherectomy or corpus callosotomy. These are all medical terms that describe the different surgical procedures that we can do. And if we can't take out the part of the brain that's causing the seizures, either because it's in a location that's too dangerous to operate in, or maybe we can't find just one spot to operate, we might offer you a brain stimulator, what's called neurostimulation, such as the vagus nerve stimulator, the responsive neurostimulator, or the deep brain stimulator. And there's other talks at the foundation I've had on these topics, so I'm not going to go into it in detail. But what about adjunctive therapy, right? So if traditional medicines are failing you, this is where we start to think about what are the other things that we can talk about doing to try to help you control your epilepsy as best you can. And that's where things like mindfulness, the use of cannabis or medical marijuana, diet therapy, and yoga can come in. All of these things have been shown to help reduce seizure frequency. So medical marijuana, and I am part of the Pennsylvania Medical Marijuana Program. So just remember that marijuana it's the cannabis plant. There are tons and tons of varieties of cannabis plants out there. And in the cannabis plant, there are tons of cannabinoids, flavonoids, and terpenoids that actually may or may not have influences in our brain. The two main compounds that we talk about are cannabidiol, which is abbreviated CBD, and tetrahydrocannabinol, which is THC. The reason this is important is THC is the molecule that typically makes you feel high. It's the one that has the hallucinating effects, makes you feel high, and is believed to have some of the potential negative psychiatric reactions that can occur. Whereas cannabidiol is a molecule that tends to have more anti-seizure properties, anti-inflammatory properties, and is used more for the treatment of epilepsy. And so when I refer somebody into the medical marijuana program, the problem is in the medical marijuana program, unlike the pharmaceutical cannabidiol preparation, if you go back a bunch of slides, there is a pharmaceutical grade cannabidiol that's pure CBD. The medical marijuana that you're going to get at one of the medical marijuana dispensaries is going to have some amount of CBD and typically THC. And so we try to get a ratio of 20 to 1. In other words, 20 CBD molecules for every 1 THC molecule, or higher. So you want more CBD and as little THC as possible. Kind of already went over this, but some of the common side effects from using medical marijuana can include diarrhea, vomiting, fatigue, and especially with the THC, can trigger some anxiety. So we need to kind of be aware of that. In order to get medical marijuana in the state of Pennsylvania, you need to go to a specific doctor that's licensed in the state for the medical marijuana program, because they need to sit down with you and understand why you need medical marijuana. They need to talk to you about the risks and benefits of taking medical marijuana, and then understand how that medical marijuana product is going to interact with your other medications. Because in my opinion, medical marijuana doesn't replace your anti-seizure medications. This is something you add in addition to your anti-seizure medications. So your doctor needs to really be skilled at understanding the interaction between medical marijuana and your seizure medications. Let's shift now and talk about the diet therapy. And so there are 3 main diets that are used for the treatment of epilepsy. The one that's the oldest and kind of the most well-known and probably the best research is the ketogenic diet. This diet is used a lot in young children, infants, young children, toddlers. It's a diet that consists of almost 90% fat, and it forces the body into what's called ketosis. And it's been shown to be very effective at reducing seizures. It's not a cure, but it helps reduce seizures. Then there are 2 other diets, the modified Atkins diet, which is a variation of the ketogenic diet. And you probably heard of the Atkins diet. It was big fad in the 2000s for losing weight. Well, the difference is now is we're reducing the fat consumption down to 60, 65%, and it lets you have a little bit more carbohydrate consumption. And then there's the low glycemic index diet, which now you can have 20 to 30% of your diet in carbohydrates, but they need to be the right carbohydrates. So it's no processed sugar, no processed foods. It's complex carbohydrates where you get whole grains and other things. And again, it's about 60% fat. So what does that look like in reality? So if we look at the pictograph on the way far right here, the standard American diet is about 50% carbohydrates, about 35% fat, and about 15% protein. So if you think about that, half of our diets are carbohydrates. These diets are extremely restrictive with much larger quantities of fat and very little, carbohydrates. The ketogenic diet is only about 2%. So there's drastic differences. And the ketogenic diet is almost not, I don't want to say it's impossible for an adult to do, but the reality is once you become an adolescent or an adult, we've all been on diets. I've done diets before. We've all cheated on our diets. And the reality is when you're on a diet therapy, you can't cheat. You need to stick to it because now you're using your diet as a form of a seizure medication. And so if you fall off the diet, it's kind of like missing medication. So you're increasing the likelihood of having a breakthrough seizure. So you need to be really strict. So typically for adults, we use the modified Atkins diet or the low glycemic index diet because it's a diet that gives you a little bit more flexibility. And if you look here, just comparing the ketogenic diet to the modified Atkins diet, in the ketogenic diet, you have to restrict the total amount of calories. You have to measure everything out very, very carefully. Typically, when you're starting it, there's a fast, although not always. Typically, it's started in a hospital, although not always. And you have to be very precise. When you're on the modified Atkins diet, you can have as many calories as you want. You can drink as much fluid as you want. You have to maintain proper ratios, but you don't have to necessarily weigh every single little thing out. And more importantly, this diet, the modified Atkins diet, you can actually go out to a restaurant these days and actually find meals that would qualify as a modified Atkins diet. So you can actually sit around the table with others and actually enjoy a meal, right? I think we forget too much that eating is not just about fueling our bodies, but it's also about feeding our soul, right? It's the communal aspect of sitting at the dinner table with friends and family and kind of enjoying a meal. And so the fact that the modified Atkins diet and the low glycemic index diet allows you to do that is also why I think it's a little bit better for young adults and adults to do. So how well do the diets work? Well, about half of people have their seizures cut in half. So there's no question that it can reduce seizures. And that doesn't sound a lot, but that's typical of me adding on a fourth, fifth, sixth medication. This is kind of the numbers that you get. So here you're getting the benefit of seizure reduction without having the additive impact of being on 2 or 3 different seizure medications. Side effects can include constipation, elevated lipids, because you are increasing your total fat consumption, and many people experience some weight loss, so you just kind of need to be aware of that. So what are the key takeaways from today? Medications, and I showed you that long laundry list of 27 drugs, there's no one right answer for you. There's usually multiple options that are reasonable for you. And we try to sit down with each individual patient and understand what individual factors do you have that will help me pick which one is the right medication for you. Because again, and I can't stress this enough, there is no one medicine. There is no test that accurately predicts what medicine to put you on. If the seizures don't stop, we're going to increase the dose. And so that's another thing that I commonly hear. Well, I called up the doctor, I had more seizures. All they do is keep increasing the medicine, because unfortunately, we have to increase the medicine to either get to that maximum dose or to the point you're having side effects. Because if you're having seizures, that means you're not on enough medication, or that's not the right medicine for you and we need to try something else. It's important to understand that how the body absorbs and uses medications changes from when you're very young to a toddler to teenager to adulthood to being an older individual, right? And that your medications may change over time and the doses may change over time. Obviously, the whole point of anti-seizure medications is to control seizures, and that's the important thing. But the medicines don't work for everyone, right? 1 out of every 3 people continue to have seizures, and that's where we need to start thinking about what are these other options out there for people with drug-resistant epilepsy. So once you've failed 2 or 3 medicines, we should be looking at A, do we have the right diagnosis? And B, what other options are there for you? And that's where It's Your Epilepsy is going to help provide useful information for you. When the medicines or surgeries don't work as expected, your doctor can evaluate other treatment options, and you might start thinking about adjunctive treatment options, as I just outlined. If you're going to take any herbal supplements that you see on the internet to improve thinking or improve your overall health, make sure you check with us, because some of the herbal supplements and vitamins that people take can actually cause severe interactions. They're not studied the same way as drugs are in the United States, right? So drugs go through the federal US Food and Drug Administration. And so they're very tightly regulated, very tightly controlled. We combine it with other medicines in trials. And so we know what to expect. When you take a herbal supplement or a vitamin over the counter, some of them we do know, some of them we don't know how it's going to interact with your medicine. So we just need to be aware of that. I mentioned that, there's, I tried to use all the generic names tonight, but obviously all these drugs also have brand names, which I know sometimes can be confusing. Some are available generic. Generics are typically cheaper than brand name medications, depending on your insurance. So you just kind of need to be aware of that. And the most important thing is just to remember to follow up with your doctor. Even if you're doing well, you still probably need to see your doctor at least once a year, once every 18 months, because we might have to do blood tests to make sure you're not having any side effects that you're not aware of. You might be having side effects that you're not aware of. So I had a patient one time, a young gentleman who came in who was experiencing erectile dysfunction. And when I asked him if there was anything wrong, he said no, but then his wife was with him and said, well, we're experiencing erectile dysfunction. And then he quickly said, well, I looked it up, it's not the drug. And I said, well, I beg to differ with you. I think it is your medication. And then we were able to successfully change the medication and resolve that problem for them. So I'm going to stop there and I'll be happy to answer any questions.
Thank you so much, Dr. Skidmore. We do have a question. Would you recommend trying medications with very different chemical makeups before seriously considering surgery? So example, a more similar chemical makeup being levetiracetam and I'm probably butchering this, brivaracetam.
You got it.
Okay.
Yeah, so the question is, would I quote unquote take somebody to surgery if you failed levetiracetam and brivaracetam because the two molecules are very similar? Probably not. We're going to want to pick a second drug that's different in some meaningful way. So levetiracetam and brivaracetam are kind of cousins of each other, descendants of each other, just like carbamazepine, oxcarbazepine, and eslicarbazepine are also kind of cousins of each other. So we would try to probably pick some drugs with different mechanisms of action.
Thank you. Yeah, please put your questions in chat and I will read them out loud. Clarissa, did you have a question? I see your hand is raised. Okay, someone asked, what are statistics of second cranie? What is that? I'm not sure what that stands for.
Sure. So cranie is a shortened abbreviation for craniectomy, which is when the surgeon has to go in and remove part of the skull to do the operation. The removal of the skull is called a craniectomy. So that's an abbreviation for that. So I'm assuming that the question is, if you have had one surgery and have failed, what is the success of going back and looking, are there more surgical options? And so actually one of the first research trials I did at Jefferson a long time ago, 17 years ago, was actually looking at this fact. So we know, again, in the right selected individual can be as high as 75% chance of seizure freedom. But again, 25% of people keep on having seizures. And so if we look at that group of people that keep on having seizures after an initial surgery and we go back and re-explore, about half of that group, if you reoperated on them, would actually become seizure-free with the second operation. So it's certainly worthwhile looking at, a first surgery versus a second surgery. Yes, we absolutely go back and look to figure out, because again, it's about a 50-50 shot, but if in the right patient, if we can find that person, there's a high likelihood that you would become seizure-free after a second operation. So I hope I answered that question.
Perfect, thank you. We have a lot of questions now. So is it common to increase dosage frequently for infants?
So infants, you have to, so infants grow fast, right? Little babies just start putting on the pounds, right? It's the only time in life you want to start putting on the pounds, right? And so little babies kind of put on weight. And so as babies are gaining weight and you're coming in for those follow-up visits, the doctor is going to adjust the dose, because infant and young child weight drugs are what are called milligram per kilogram. So every time you gain a certain amount of weight in kilograms, the doctor is going to have to adjust the milligram value to make sure that you're on a dose. So you're going up on the dose of the medicine, but in reality, it's really the same dose, because it's just you need more because your body's bigger.
Thank you. How do you feel about filming seizures for documentation purposes?
So I think that's you want to. I think that's hugely important. You mean as far as showing your doctor what a seizure looks like? So yeah, I mean, so I've been in this game long enough that 17 years ago we all didn't have video cameras in our pockets, and now every single one of us walks around with a device that has a video camera. So a picture, or in this case, a video, is worth 1,000 words. So many of you have probably struggled to try to describe what a seizure looks like. And I've had people bring in videos, and within seconds, I can look at it and go, I know exactly what you have by looking at that video. So if you have the chance to get a video of somebody having a seizure, that is hugely important to share with the doctor. And they can really learn a lot from that.
Great, thank you. Okay, someone wrote, my 10-week-old is on Trileptal and Keppra and has had 3 increases in 3 weeks. Is that a common thing?
So it's very challenging to answer that question, because it's a very unique and very specific kind of question. There could be reasons why the doctors are going up on those medicines. One could be that they're checking blood levels and the drug is not reached a good level in the bloodstream. So blood tests help us tell roughly where people need to be in their bloodstream for these drugs. So that's one reason why they could be increasing still. Or you could be still having lots and lots of seizures, and they're trying to go up as quickly as possible to try to get the seizure under control.
Okay, thanks. What are benefits or downsides of generics versus brand?
So I am a big believer in using generics. There is a growing literature that says, so in other words, on the market, if there's a branded drug and a generic drug and you have the option of getting one or the other, I would say that you should get the generic medication. They're infinitely cheaper, both to you as well as to our society as a whole. The molecule, the active molecule, the drug itself is the exact same drug that's in the branded drug. It's just that it's manufactured by a different manufacturer, and what they use to put the pill together might be a little bit different. So there's been numerous studies done. Now there's one exception, phenytoin or Dilantin. Because of the way Dilantin is metabolized in the body, it's very, very challenging, and small adjustments or changes in dose can have a huge impact on drug levels. So that's one where I do want to keep people consistent. What I try to do with generics is I try to get people on a generic, and if they're sensitive, I try to stick with that same generic from one prescription to the next. So we might say we want generic from manufacturer A and ask the pharmacy, can they stay with that from manufacturer A? So I don't think there's a big difference between generic versus brand for most of the seizure medications.
Thank you. Okay, how many different mechanisms are there that the drugs address? Do the drugs address all of the mechanisms?
So we have, you're taxing my addition skills here, but there are probably currently, let's see, sodium, calcium, potassium channel, the NMDA receptor, which is a couple of subtypes of that, the synaptic vessel 2 protein, chloride channels, GABA receptor. So there's probably around 7 or 8 different mechanisms of action for drugs that are available currently in the United States. So we have drugs for almost all of the mechanism of action that we're currently aware of, but that's what we're constantly doing. Pharmaceutical companies and scientists are constantly doing research to figure out other targets that we need to be looking at.
Great, thank you. If I am a candidate for surgery, how do you know that I still need to continue with medications?
So if you're a candidate for surgery, and we do surgery, we're going to keep you on your medication. And again, I'm going to share with you my personal plan that I do with most of my patients. So I try after surgery not to change your medicines at all for the first year, because your brain is healing, you're recovering from the surgery. We want to make sure you're completely healed, and hopefully you're 100% seizure free. Then typically between year 1 and year 2, try to slowly get you down to 1 seizure medicine at a dose that you can tolerate without side effects. Now, will I lower medicines before 1 year? Of course, if you're having major side effects, we're going to have to adjust medications early. Then from year 2 to year 5, I try to keep somebody on 1 medication. And then at year 5, we have the conversation of, do you want to kind of roll the dice and take the chances of coming off medicine and to see what happens? Because if you've been seizure free for 5 years, the challenge is, I don't know, are you somebody that still needs to be on that low dose of that medication, or are you somebody that's been cured? We do EEGs. We look at the MRI to say, oh, your surgery looks good. The surgeon did what I expected them to do. We'll do an EEG, and hopefully your EEG is normal. But even if the EEG is normal, it doesn't mean your risk of a recurrent seizure is not 0. And so then it really comes down to a personal decision. And luckily, with the modern seizure medicines that we have, many of our drugs have no evidence of any long-term toxicity. So if I have you on a low dose of a drug with no toxicity, well, you may not want to come off that medicine. If you're living, out in Scranton, Pennsylvania, and you have to drive everywhere, and then I tell you you're going to come off, and if you have a seizure, you can't drive for 6 months, are you really going to want to roll those dice? And so it's a very individual decision, and there's not a right or wrong answer.
Thank you. Are there any innovations related to epilepsy treatment that you are excited about?
Yeah, so I think there's new drugs that are constantly coming on the market, and I think that's always a very exciting thing. There's about another 2 drugs that are currently being researched. So, and every time we get a new medicine, it's a chance to hopefully help somebody else. I think one of the exciting things has been the rescue medications, the nasal rescue medications that have come out over the last couple of years, because it's much easier now for people to administer a rescue medication by just kind of giving a spray kind of up the nose. So I think I'm excited about that. We're going to see the development of new brain stimulators to treat epilepsy, and I think that's also, I think, very exciting.
Wonderful. Okay. Many school-age students become drowsy during the school day on AEDs. Many students are on Keppra. Should dosing and timing of medication be adjusted when this occurs, even if they have been seizure-free on their current medication plan?
So yes and no. So I think, we try to adjust the dosing schedule. So if many of our medicines that are dosed twice a day, it's not uncommon that peaks in your bloodstream. So when you take it by mouth, it peaks in your bloodstream in about an hour or 2 for most of the meds. So you might want to adjust the dosing to be early enough so that the peak is happening before school actually starts, and maybe that might avoid some of the side effects. Some of our drugs are once-a-day medications, and some of our drugs are extended release versions of medicines that are usually twice a day or 3 times a day. And so, if you're having side effects that's impacting schoolwork or impacting work performance, we might transition to a dose of an extended release product at home at night. So that way, when you're at school, hopefully you have a lower level in your bloodstream and you can function better. It's a great question.
Great. Can you explain the difference between RNS and DBS?
Sure. So RNS is called the responsive neurostimulator. So the RNS, I, as your physician, has to understand what 1 or 2 spots in the brain are causing your seizures. And then we actually place electrodes directly on the brain in those spots that are causing the seizures. And then that gets connected to a device that gets implanted under your skin. So we carve out part of the skull and we put a little metal cage and the device sits there. So once your hair grows back, people can't tell that you have it. And that device records your seizures, and we teach it to recognize your seizure pattern. And then it shocks your brain, kind of like a heart defibrillator. It shocks the brain in this case to shut down the seizure. Whereas the deep brain stimulator, many people may have heard of it and used for Parkinson's disease. So that it's the same technology, but now we're targeting a structure in the brain The most common target is the anterior nucleus of the thalamus. And it's been shown that and we put an electrode, one on each side, but the wire goes down your neck, and then it's like a little pacemaker sits in your chest. And we then turn that device on and off throughout the day to stimulate the anterior nucleus of the thalamus. And that's also been shown to reduce seizures.
Great, thank you. Can an EEG pick up all seizures?
So not all, a scalp EEG, so EEG with electrodes on the head, no. Seizures that are the focal aware seizures, the ones where you do not lose awareness or lose consciousness, we probably only can record about 15% of those. So 85% of them we don't actually see on EEG. And that's because they're either the amount of brain tissue that's causing the symptoms is so small we can't detect it. Because remember, if I'm recording from an electrode on the scalp, it's got to go from the brain through the spinal fluid, through the bone, through the skin and muscle, and get all the way out to the electrode, right? So we lose a lot of the signal. Intracranial EEG, where we put EEG electrodes directly into the brain to precisely map out where seizures are coming from, that we should always pick up the seizure. And if you're not picking up the seizure, it means your electrodes are not in the right spot.
Okay. Can your seizure types change as you age?
So the type of epilepsy you have, focal and generalized, doesn't typically change. That usually stays the same. The things that you do during a seizure, though, can change over time, partly because of the medicines you're taking. So hopefully, if you had focal to bilateral tonic-clonic seizures and focal impaired awareness seizures, and we put you on a medicine, hopefully it stops all your seizures. But if not, hopefully it stops the tonic-clonic seizures, and you're having less of the focal impaired awareness seizures and maybe more of the focal aware. So it's usually the treatment that's altering as opposed to your brain aging.
Okay, great. All right. Someone wrote, my daughter is 4 years old with intractable epilepsy since her first month of life. At the moment, she is controlled with medication. What is the probability that her generalized seizures have a focus with the growth of the brain?
So seizures that start in the very, very young. So when we're born, our brains are not mature, and they really don't mature fully until kind of late teenage, early adolescence. And so it is possible that you could get a brain scan done on a baby that's 6 months old and not see something, and then repeat it years later and see something. So yeah, that's one of the reasons you need to follow with your doctors. Now, if you're controlled at this point, and big scary things like tumors would have been seen. What I'm talking about is very subtle birth defects or subtle changes in the brain. If you're following with your doctor and your seizures are controlled, and your child's 4, it's probably not worth getting another MRI because you have to use anesthesia. And every time you use anesthesia to put a child to sleep, anesthesia is good, but every once in a while there can be a complication, right? So you want to weigh the benefits and risks of, is it worth going under sedation to get another MRI or not? And so, and that's again, a very complicated decision, but certainly something you should discuss with your doctor.
Thank you. What is your experience with the drug called Xcopri?
So Jefferson, we were part of the original research trials that brought Xcopri to market. So we've had extensive experience over the last 8 years, I think at this point, or maybe close to a decade. So we've had lots of experience, and we've had lots of patients that have had a dramatic response to the medication. That's probably the most exciting new medicine to come to the market in the last 30 years. In the research trial, 1 out of every 4 people became seizure-free. We've never seen that in any of the other research drug trials. So so we've had a very positive experience. Again, it's a drug that has to be started slowly. It takes 3 months to start. And there's a lot of very specifics as to whether it works or not for everyone. So, it's certainly worth discussing it with your doctor.
Great. Do you know if nasal medications are more affordable for families versus rectal?
So I do not know the answer to that question. I'm going to hazard to say the rectal is probably cheaper than nasal, and because the nasal are brand new and they're branded products. But I do not know the answer to that. If you're ever wondering about the cost of the medicine, you can go to goodrx.com. So GOODRX.com. And you can type in the medication and they'll tell you what the cost would be if you just went to a pharmacy to try to purchase it. But obviously that doesn't answer what your insurance company would charge you.
Okay, another person wants to know, is it possible that there could be any external devices like RNS that could be developed?
So I'll tell you, there's lots of interesting research being done in this area. So for instance, in the migraine world, they've actually found that stimulating the vagus nerve, the same nerve that we stimulate for epilepsy, can be used to actually acutely shut down migraine headaches. And so they've actually developed some external stimulators, but there really hasn't been a trial yet to see would that be effective in adults. There's all kinds of interesting neurostimulator research. So if you stimulate the rat's tail that has epilepsy, it'll actually reduce the seizures. There's human studies where if you stimulate the trigeminal nerve up here on your forehead, that you can actually reduce seizures. And so I think we may see in the future maybe somewhat less invasive devices or different ways of stimulating the brain, but we're still probably at least 8 years out for some of those things.
Cool, very interesting. I think that was the last question. So thank you everyone for all your wonderful questions. And thank you, Dr. Skidmore, for that informative webinar.
My pleasure, thank you.
Thank you. So before we end tonight, we just wanted to share some additional information. So let me share my screen here. And Clarissa, if you would like to talk a little bit about it'syourepilepsy.com resources.
Sure. So after this webinar, everyone will receive a one-pager that kind of just summarizes the key takeaways that Dr. Skidmore explained at the very end. You can also find our first one-pager, which is a summary of how to prepare for your appointments. It really takes you by the hand and makes sure that you bring all of the necessary information that your doctor will need so that you can have a more successful appointment. And then we have a trifold about it'syourepilepsy.com that would really summarize all of the great information that you will be able to find in the future once our website goes live at it'syourepilepsy.com. Thank you, Rena.
Thank you. And here at the EFEPA, we have a lot of upcoming events and webinars going on, and this will be emailed to you as well. So we have our Charlie Roach Golf Invitational, September 28th. We have 2 virtual epilepsy education conferences. Our Northeast one is October 20th. Our Philadelphia one's October 30th. We have our Walk to End Epilepsy, NEPA's October 2nd, and the one in Lancaster is October 16th. We are going to have a pediatric surgery webinar series in November. More details to come. And we have a Spanish epilepsy webinar, La Epilepsia y Tú, November 2nd. So thank you all so much. And this will be emailed to you. And just please stay connected to us at the EFEPA. We have a website, Facebook, Instagram. You can email us and call us. And now I'm just going to quickly launch a poll to get some feedback from you all. So if you can take a minute and just answer these questions. Thank you all so much. And have a great evening, everyone. All right, everybody, good night. Thank you so much. Take care.